Okay, fine. So today's, when you see this thing about before the discovery of the penicillin 1942, even a simplest like tonsillitis, pneumonia, scarlet fever, typhoid, typhus, tuberculosis were incurable. They were, you remember the sanatoriums of tuberculosis, one of the first sanatorium in 1900, they had the sanatorium which was there. The hospital were full of people with sepsis contracted from cut or scratch, even a small cut or scratch, especially in diabetic or older, this thing, they would go for cellulitis and all that, they go for a shock. And doctors could do very little for them and just hope that in England they were using for the bloodletting. They thought this foul blood would get, if it gets out of the body, patients would get cured. And there was a dramatic change with the introduction of penicillin in 1940 by Alexander Fleming. That's the time when began the era of antibiotics. It is recognized as one of the greatest advances in the therapeutic medicine. And penicillin was successful in controlling bacterial infection. They said, actually, one of the Surgeon General of America said, the chapter of infectious disease will be removed from the textbooks of medicine. Imagine, this was almost about 70, 80 years back. But now where we are at where we started with no antibiotic there. Penicillin was a miracle drug against staph aureus because that's the time there were a lot of wars which was going on. The wounds from the wars were there. After 1 year only, the staph aureus started showing resistance to this miracle drug. Initially limited to the hospitalized patients, but even in the community, it started becoming this thing. So 1960 was a time when there was first semi-synthetic penicillin, what is called as a methicillin. What is there? It's not available now. After 2 years, the staff again started showing resistance to penicillin. So initially it was present only in the hospital. Later it became irrelevant and prevalent in the community. As early as 1945, Sir Alexander Fleming raised this alarm. Please don't use it irrationally. It can result in resistance. So overuse of antibiotic clearly drives the evolution of resistance. Epidemiological studies have demonstrated a direct relationship with the antibiotic consumption and emergence and dissemination of resistance of bacteria. You just seen people just walking to the pharmacy demanding, I have a throat pain, give me antibiotic. I have malaria, body ache, headache, give me antimalarials. I have diarrhea, give me ornidazole or metrogel or some other antibiotic. This is what you see in every pharmacy which is there. There was in Connecticut, I think this was around 1942 in USA, there was a lady with the infection with just deadly streptococcal sepsis. So the doctor who was treating that told the patient party that there is a new drug which has been sort of come and we don't know anything about that. Are you willing to take a risk and use the thing? And they gave the penicillin and miraculously that lady survived. 66 years down the line, a man in San Francisco recently, he had the vancomycin resistant E. coli, enterococci, endocarditis, and he dies in bacteremia despite of using the best antibiotic, teicoplanin, meropenem, vancomycin, you name it, actomycin, all that daptomycin, all that was used. But why? Because chief reason for your use and misuse of antibiotic has resulted in that. We don't have any more antibiotic. It's a high time, all of you, as a undergraduate students who are coming up, you should get sensitized about antibiotic stewardship. So what are the reasons for the misuse of antibiotics? It's availability of antibiotics over the counter. I told you can just go there, give me cefalexin, give me augmentin. You just take it and use it. Poor knowledge of the public about need the antibiotic properly. That means they will take for 3 days and stop it. They take for 1 day, fever comes down. It would have been a viral fever. Use of antimicrobial agent in the veterinary practice. There's a large, because if you see, the amount of antibiotic, almost about half the antibiotic thing goes to the veterinary practice, because especially the cattle rearing countries, or the fowl, that is that your chicken, they use a lot of antibiotics so that these the veterinary the birds or the cows will not get this infection. So our Indian, this thing, there is many, if you see, one of the maximum inappropriate formulation and irrational drug combinations originates from India. And our FDA, it's a high time they should take a note that it's not needed, because most of the physicians, how many, 20, 25 drugs is all that is not. We have 3,500 formulation in our armatorium. So availability of substandard, some from China, and expired date drugs which are sold because nobody sees the expiry date, and incorrect promotion by pharma companies. They say, and most of us, what happens is after we finish our MBBS or MD or super specialty, we have become so busy. We don't have time to read. And whatever the pharma person or a rep, MR comes and tells you, sir, this is the best antibiotic which is there, kindly use it. The tonsillitis goes, you say, oh, is it? You start using it without reading, without knowing what are the side effects, without knowing what to be used, what not to be used, we use it. Over the time, this is what the sad state of affairs of a doctor. It is so important that we need to work on our continued medical education so that we know what is right or not. But undeniably, major cause of increasing antimicrobial resistance is the misuse of antibiotic by we clinicians. Let's introspect ourselves. We have a very high rate, because many times we see the prescription 1, 2, 3 antibiotics. You have one organism causing the thing, but you have 3 antibiotics trying to use it. It is like hitting a housefly with a cannon, something like that. Do we need it? It's a high time. Even if you start an antibiotic, 2 antibiotics, if you say culture comes and it is sensitive to a particular antibiotic, it's a high time. We should stop the antibiotic. We had over the time penicillin, then we had a croxacillin, amoxiclavin, cephalosporin. Now we had a vancomycin. We had linezolid and daptomycin. These are all the higher and higher antibiotic we go. But earlier and earlier, they get the resistant to the organism. I still remember when I first came in 1990s to India, and meropenem had just come, and meropenem was 100% sensitive almost for a year. Then slowly the resistance started coming up in our pediatric intensive care. And now it is only about 60% to 65% of this thing. What this irrational use of antibiotic has done to. So what does it see? Bacteria and viruses are there almost about 5 billion years. Human as Homo sapiens are there for about 1-2 lakh years back. So they know the tricks of the trade much better than us. So what they did was, as we gave the beta-lactamase, anti-beta-lactamase enzyme. So what we did is they started producing extended spectrum of beta-lactamase producing against this gram-negative bacterial infection, especially in the UTI and sepsis. Then they started having the resistance to vancomycin, whether it's Staphylococcus aureus or Enterococci. Then the terrible thing is multi-drug resistant. Any drugs, the normal drugs, what we have, this thing is not acting against tuberculosis. Many of the students from Bombay, Ahmedabad, all that, they had many XDR-TB, that is extremely drug-resistant tuberculosis. Then in 2012-14, we had what is called as a New Delhi metallobeta-lactamase, NDM. It was resistant to meropenem, it was resistant to vancomycin, it was resistant to all those drugs. It was called as superbug, because one of the patients who had gone from Delhi to UK, where he had fever and sepsis, they used this antibiotic, but it was resistant to everything, other things. So MDR typhoid fever, recently you heard in Pakistan that typhoid which came for resistant to azithromycin, ceftriaxone, all those drugs, it was this thing. So study finds 1/4 of child has got multi-drug resistant TBs in India. So our Prime Minister has told nil TB, NTB by 2025. But the problem is the drug-resistant, multi-drug resistant tuberculosis is there. Second highest after China, So it has got about 2 to 3% of new cases, and 12 to 15% of reinfection cases are drug resistance. And extremely drug resistant constitute about 99.7% of MDR patients as reported by WHO. So this is one which had recently, 2-3 years back, it came, typhoid superbug. That's why India had to donate typhoid vaccine to them to control the typhoid. So what happens is that this was H58 strain of MDR. It was resistant to everything: chlorphenicol, ampicillin, cotrimoxazole, and in its gene itself, it has had the thing. And this is one of the patients which we saw in our OPD, which the child came with 7-month-old child with 2 days of fever, cough, and cold. He was seen by a GP who had given all this antibiotic. Just see the antibiotic that contains norfloxacillin and metronidazole, then cephaloxime, ondansetron for vomiting, paracetamol, cofarest for the cough, and zero cold is for the cold. So many medicine for a 7-month-old child. Why does he read this antibiotic? It is definitely a viral fever of 2 days. You can always wait for that. This was again a child who has got 1-year-old child with fever cough 2 days. Microceph, that is Cephalox, cefixime. All this antibiotic and all that is not needed. 2-year-old child with 1 day history of watery stool. He's been given ornidazole, norfloxacillin combination, cyclopam, meftal, so many drugs for a small kid like this. Is it really necessary? That is what we should introspect. Is it watery diarrhea, loose motion? It's 90% is because of the virus. So why do you need an antibiotic for this? This is one more child with the hand-foot-mouth disease. You all seen a hand-foot-mouth disease. It's a viral disease caused by either Coxsackie or it's by the enterovirus 171. So it does not need antibiotics. See, you see the prescriptions given by somebody, one of us, that is cephaloxime. For what reason? He never had any other symptoms. All these medicines are simply given to this patient. This is viral bronchitis. Viral bronchitis, do you need cephaloxime? No, it comes down by itself. Please don't use this antibiotics for all this viral bronchitis and all that. What I advise my students is always when you give a prescription, make sure you write the diagnosis. When you write viral diarrhea, you will be hesitant to write an antibiotic because you have put a viral. If it's viral bronchiolitis, you will be hesitant to give an antibiotic. So that's how you should control yourself and do it. So it is battle of the bugs. And antibiotic resistant, we are more human. Man, what it does, he'll try to make something which overcomes that. But it's a battle of survival. Antibiotic is smart. Man tries to be smarter. Antibiotic will be smarter. Bacteria is smarter. So that's how the antibiotic resistance is there. So why do we have to worry? Bacteria is increasingly become resistant to treatment of this thing. Because in our ICU, what I'm seeing is, many of the time I have to use higher antibiotic. The ampicillin is not acting. Amikacin is not acting. There are no new antibiotic to fight the resistant bacteria. So we are entering the pre-antibiotic. See, every antibiotic which is produced is resistant to the bacteria. Then what do we have? We go back to the 1930s where we had what is called as a pre-antibiotic area. That's why we need to conserve the antibiotic. We need to use them rationally and judiciously. So what does WHO says? Antibiotic resistance is rising in dangerously high levels in all parts of India, all parts of the world. It is not India. Everywhere it is more. New resistant mechanisms are emerging and spreading globally. Because, as I said, bacteria is so smart. Everything we throw at them, they'll try to change their mutate and try to change it and overcome the antibiotic. But undeniably, major cause of increasing antimicrobial resistance is misuse of antibiotic by weak level. We should introspect ourselves. Who is responsible? Who is giving all these antibiotics? Is it necessary really? What are the highest misuse of antibiotic happens with us in our individual practice? High rate of irrational prescription. That's why we have what is called as an antibiotic audit. We take out all the antibiotics, what we have, the cases where we have this thing, and we made the postgraduates and everybody to read about it and tell us whether it is really necessary or not. And we introspect. We all make mistake. I also many times irrationally might have prescribed, but it's a time for us to introspect ourselves and see whether it's right or not. So high rate of irrational prescription of antibiotic leading to superbugs. You said, well, vancomycin resistant, Staphylococcus aureus, carbapenem resistant enterococci, ESBLs, multi-drug resistant TB. All these are superbugs which are waiting there, and it can happen to any of us. So there we have what we call as a era of superbugs and phantom menace. That is, many public officials, including CDC director, they have called that carbapenem resistant. It's a phantom menace. That is, it is going to have a big problem through the thing. Just see here, this is new drugs in the pipeline for the antibiotic which was approved by US FDA. See, 83 to 87, there were almost 16 new drugs. See what has happened in 2008-9. So 18-19, it's still lower than that. So over that time, we don't have any antibiotic coming in the pipeline. And to produce an antibiotic, it takes billions of dollars to produce that. So that's why use judicially. Take care of your antibiotic with this thing. So it's a presentation which we have done. So what are the most common complaints for which the antibiotics are prescribed? Basically, what the patient comes with, he comes with a cough and cold with fever. You think it's infection. Fever, loose motion, vomiting, dysentery. Skin infection like cellulitis, boils, abscesses, impetigo. Fever, cough, difficulty. Well, these are the four things. 90% of the time, they come where you will prescribe antibiotic for the patient. So without antibiotic, you can do so many things. Some of the hospitals, common surgical procedures like cesarean section, gut surgery, joint replacement, cardiac surgery have become too dangerous to perform because of the resistant thing. He comes walking and gets into sepsis and goes back in the ICU. Especially, it's a lurking fear of a hemato-oncologist in cancer patients, transplantologists, and infection in chronic like diabetes, end-stage renal failure, rheumatoid. They are prone for a severe infection. So that's why we are all scared of that. And as I said, WHO warns again the post-antibiotic era where we will not have any antibiotic which can act. Antibiotic drugs are precious but infinite, but has a finite resource. Need of the hour is judicious, appropriate use of antibiotic. Race against time to develop new antibiotic. How many are there? Need for most important thing as a doctor, what we can do? We can do what is called as the antimicrobial stewardship is this thing. So how do you prevent antibiotic resistance? Encourage rational antibiotic therapy. Helps by reducing antibiotic pressure in individual, hospital or community. Use of combination therapy selectively. Use for TB, malaria, where we are using 2-3 drugs. But generally not for bacterial infection. You can use for that. But for an acute bacterial infection, it just needs a single monotherapy. Practice infection control. So you make sure your ICU, you make sure the home, you make sure the society, and make sure that that whole area is less infectious, like your excreta, the water, all those things will be there. It reduces the risk of nosocomial infection and hence reduces the thing. And promote immunization. So many things where it can be prevented. Better to prevent rather than treat. What are the don'ts in antibiotic therapy? Prescribing antibiotics when not indicated. A child with just a viral flu-like symptom. Why do you need an antibiotic? Polytherapy, 2, 3, 4 drugs. Antibiotic, not necessary. How much ever the infection, it will only act with one drug. Using higher antibiotic for routine community. A child comes with a little lower respiratory. Why do you need to use ceftriaxone? Why do you need to use vancomycin? Using more than one antibiotic when not indicated. Subtherapeutic doses. See, you're supposed to give, say, amoxicillin say 50 milligram per kg, you are giving 20 milligram per kg just to save some money for it. No, it will have resistance. Insufficient duration, use for 3 days instead of 5 days. Changing antibiotic too frequently, he'll come for 1 day fever, you give one antibiotic, after 3 days he comes and tells you the fever has not come down, he'll add one more antibiotic. After 5 days he'll come again, you'll just change and use the third antibiotic. It's a time, instead of changing the antibiotic, you should be looking at where I've got wrong, where I've missed. Take the history again, do a physical examination again. Using irrational combination also will result in antibiotic resistance. So fever, let me go through multiple cases to sort of illustrate how this antibiotic resistance can happen and what are the problems what we have in a clinical scenario. 11-month-old child, sudden onset of fever, 100.5. Vomiting at the onset of the illness, followed by watery loose stools for 2 days. He sees a GP who puts him on ofloxacillin ornidazole combination. This is a second case. 2-year-old boy, cough, watery nose of 1 day duration. Fever is 102 Fahrenheit. Parents have similar symptoms. Cefodoxime started. Case 3. IVF baby. You know, IVF baby, precious baby, LSCS at 36 weeks, electrically done, it is 2 kg. There was no risk factors. Baby cried immediately, perfect this thing. Just because it was IVF baby and a precious baby kept in nursery for observation. So prevent infection was given cefodoxime and amikacin as it's a precious baby where there was no indication. Comes back a week later with sepsis due to ESBL produced because in the NICU, there were other babies who have got a severe multi-drug resistant sepsis. Poor baby who went sterile came out with the sepsis and just had a very, very bad sepsis. So there was no indication to start antibiotic in the last 3 cases. So first case, watery diarrhea. It is 95% of the time it's a viral diarrhea. Watery nose, it's a flu-like illness, so it's a viral. Precious IVF baby, you do not need, unless there is an indication. He had fever, baby was not sucking well, signs of sepsis was there. There was no indication to start. Now, this baby got a resistant bacteria, which is difficult to treat in the child. So, one more case, that is 2-year-old asymptomatic child with a contact with tuberculosis. Maybe grandmother, grandfather was there. He was put on INH prophylaxis. Develop fever, cough, weight loss, go to the second pediatrician who adds rifampicin. What should have been done? Once developed fever, weight loss, a history of contact is there, you should have investigated for tuberculosis and put him on a full 4-drug regime in the initial this thing. So, the child did not get better. Chest X-ray showed massive lymphadenopathy. Gastric lavage showed mycobacterium, which was resistant to all the first line treatment. What was the error? Error was that you should have started with all 4 drugs. Insufficient drugs, insufficient dosage, and we didn't continue for the thing. So 18-month-old child with fever, irritability, red bulging eardrum. Diagnosis of acute otitis media. She was put on amoxiclav in a correct dose. But parents thought doctor is always there. They say he's giving strong medicine. He's giving this thing. So they don't think that it is the right dose. So they themselves reduce the dose to half as child developed diarrhea with the full dose. Because amoxicillin is a gut irritant, they can have diarrhea as such. 4 days later, still running fever, throws a convulsion. Bulging anterior fontanelle. CSF grows, beta-lactam is producing H influenza. So what was the error? That there is an infection in the ear which is near to the brain. And you have given at a suboptimal dose. So bacteria has been growing. It has gone to the brain and gives rise to the CSF infection. That's meningitis. Preterm, lethargic, seizures on the 4 days. CSF suggestive of meningitis. Started on cefodoxime, amikacin. Improves. Child is better. Looks fine. sent home on oral antibiotic as the child, because this many of us in a neonatal this thing find it after 10, 12 days, their parents feel that, okay, child is better, we can't afford it, let's take it home. This is what has happened. Comes back a month later with brain abscess due to ESBL, extended spectrum beta-lactamase producing E. coli. What's the error? Comes back, see such a bad brain, this baby will never be normal again. Such a big abscess is there. So what has happened there? So the thing, what is the problem? Inadequate dose of antibiotic leading to worsening. All three cases you see, it was inadequate dose of antibiotic which is causing it. 24-day-old neonate was brought with the refusal to feed and fever for last 24 hours. He was hypothermic, limp and groaning. Would you start antibiotic? Definitely. The child has got a signs of sepsis, 24-year-old, because what happens, anybody less than 3 months, this child is sick, fever, hypothermia. They can have fever or hypothermia. Child is in septic shock possibly. So you need to start on antibiotic. And wait for the results of your test. 2-year-old boy under the treatment for acute lymphoblastic leukemia. His hemoglobin was 8, anemic. His total count was only 1080. Neutrophils were only 20. That is, absolute neutrophil count was 204. What is it called, this condition? Febrile neutropenia. He had anorexia and fever for 1 day. Do you want to start antibiotic? Yes, I would start on antibiotic in this child. 3-year-old child who had a splenectomy 6 months ago because of RTA, but he got all those pneumonia, pneumococcal, meningococcal, hip vaccines to prevent any infection. He was on oral penicillin prophylaxis. He comes with fever for 102. No focus. Do you start on antibiotic? Yes, we start on antibiotic. Why? Waiting in these conditions is dangerous because, newborn, anytime within minutes they can go off. Other child was a febrile neutropenia, hardly any immunosuppressed patient by the drugs. Third is that splenectomized patient, they can go because complement thing is not working properly. So that's why you need to start an antibiotic, and we cannot wait in this condition. Send investigation and start antibiotic, and you can stop the antibiotic if you find all the bacterial markers are negative. This condition is called what is called as a presumptive empiric use of antibiotic. So empiric use of antibiotics, if high probability of bacterial infection and waiting is dangerous, or you saw in the first baby, it's a life-threatening, baby is already in shock, or you saw in the second case, what is the thing? It is a ALL, immunocompromised. You have a very low neutrophilic count. So febrile neutropenia, you need to start on antibiotic in this child. So let's go through again these cases. So 4-year-old, she has a submandibular swelling. You can see here. So diagnosed by acute suppurative lymphadenopathy. Do you start an antibiotic? 2-year-old child, toxic looking, high fever for 2 days, blood and mucus in the stool for 1 day, diagnosed as bacillary dysentery. Do you start on antibiotic? 1.5-year-old child, fever, cough 3 days, breathlessness 1 day. He is looking sick, febrile, crepitation on your clinical pneumonia diagnosed. Would you start on antibiotic? 5-year-old boy, fever since 5 days. He has got a poor appetite. He is sick looking, toxic, coated tongue, soft, and he's got a hepatosplenomegaly. Do you start on antibiotic? So 2-year-old, fever 2 days, crying, fever for 2 days, crying on passing urine showed 40-50 pus cells. Do you start on antibiotic? In this, all 5 cases, when you see that in the submandibular region, you saw it's a reddish, hyperemic, looks like a bacterial lymph node. Similar way, all those 5 cases, if you see, there was the pointer for sickness, pneumonia, bacterial. This could be a typhoid. Yes, you take the thing. And this could be bacillary dysentery with blood and mucus. So all these 5 cases and other one is urine which showed pus cells. So send appropriate investigation and start on antibiotic. So this is all what we call as an empirical use of antibiotic. This is antibiotic used empirically in last 5 cases. And in this clinically, bacterial infection was obvious. This is a 5-year-old child with a progressive fever, anorexia, occasional vomiting, and soft hepatosplenomegaly. Soft abdomen and hepatosplenomegaly. And this was not, it's almost like a normal, this thing, blood culture started on ceftriaxone. And blood culture grew staph typhi, staphylococcus, Salmonella typhi, which was sensitive to ceftriaxone and azithromycin, but resistant to quinolone, that is your ciproflox, ofloxacin and all that. So he was already on ceftriaxone, which was sensitive to ceftriaxone, and this doctor added azithromycin. So is the combination of antibiotic justified? No, because it's already sensitive to ceftriaxone. There is no need to add another antibiotic. A child with peritonitis followed by ruptured appendicitis, being treated with ceftriaxone, amikacin, this thing. Is the antibiotic justified? Febrile neutropenic patient, a combination of piperacillin, tazobactam, and this is, yes, it is justified in this thing. So what is the combination of 2 or more antibiotic? When do you start? Serious bacterial. You saw all those were serious bacterial infection. In hospitalized patient, presumptive antibiotic. A child comes with a septic shock. Very sick patient. You start the antibiotic and then take the cultures. 2 antibiotics. And then depending upon the result, you can do that. Mixed infection. More than one organism. For example, a child who has come with a RTA, road traffic accident, contaminated wounds, perforation of the peritoneum, all that. Development of resistance. Say, for example, it's a slow-growing bacteria. So what do you do? Virus. So like TB, HIV, falciparum, malaria, you need to use combination of the drugs. And true synergy, penicillin and aminoglycoside like streptococcus viridis, endocarditis, they use a sort of a synergic mechanism to kill this bacteria. So combining antibiotic, what can happen? Like synergism, we can use penicillin, aminoglycosides, then you have tetracyclines with beta-lactam for streptococcal viridans. Addictive like rifampicin with infection with the staphylococcus vancomycin with MRSA. Indifferently cefixime and azithromycin for enteric fever we can use. Let's go through again a case. This is a question for you, but I won't be able to find out like whether all of you are acting, but try it out. Try it for yourself and see the thing. A 7-year-old with a recurrent multiple pyoderma with no response to topical therapy. Which micro? So you have given fudic acid or mupirocin, but it is not improving. So the doctor decided to add a oral antibiotic. Which one? It is cephalexin because it's a first generation cephalosporin. Very good. Possibly it is staphylococcus or streptococcus. So it is both sensitive to this oral antibiotic. 3-year-old fever, cough, cold, difficulty in swallowing in 2 days, history of similar illness in younger sibling. Febrile vitals are normal, congested, enlarged tone, few cervical nodes, non-tender, oral cefixime is start. Do you think it is right? Antibiotics are justified? No, because what has happened, there is no follicles, only congested. Viral tonsillitis can also happen. And also there is another sibling who is infected. So possibly it is viral. Bacteria won't spread like that. So it is the viral. So you should always think, I've seen so many of my postgraduates also just say it is congested and start antibiotic as if antibiotic will help that. In this presentation, suggestive of viral RTA because of the age, presence of coryza. That also is more looking towards the viral. Similar sibling with this thing. No pus points on tonsil. Antibiotics were not indicated. And that too, cefixime is not an antibiotic for respiratory infection in young children because it does not cover pneumococci. So pneumococcus is the community acquired Streptococcus pneumoniae is the commonest organism. So you have this thing. So returned one day later with the continuous fever and so throat swab culture was sent. So his fever didn't come down even despite of they starting on cefixime. So is it really needed for a throat swab? Because it's an expensive test. Nowadays, a throat swab will cost you almost towards $600-800. So throat swab is indicated only with the presumptive diagnosis of bacterial sore. You can't see it. Viral sore throat travel will show some beta group A beta hemolytic streptococcus, and it will come with a commensal with many different sensitive to antibiotic. You will also start with a different antibiotic. If sending a throat swab before starting an antibiotic, it is of no use. So child was already on antibiotic. So there is no need to start on antibiotic. 2 days later, child is better. Culture was beta hemolytic streptococcal resistant. Antibiotic changed to coamoxicillin. Child was better. Child, do you think, what is this? So it's usually sensitive to penicillin. Lab should recheck the sensitivity report. Prescribing antibiotic at the outset was the first error. And doing a throat swab was a second error in this child. And changing to coamoxicillin was a third error because child was better and we had thought of viral this thing. It is of no use of this thing. See, all should know about the difference between a viral and a bacterial infection. This is how they come in your clinical practice. So in a viral fever, what happens is it's a high fever at the onset, better by day, third or fourth day. It's a biphasic, but that 2-3 days fever, no fever, then again have fever. Child will be always non-toxic, and in between the fever period, they are active playing and all that eating. And usually disseminate. So multi-system involvement is there. And more than one member in the family or in the school will be affected. Bacterial usually start with a lesser fever by 3rd, 4th day peaks. Sick and toxic. Interfebrile period not normal. Localized to one side. Say, for example, if it's UTI, urinary symptom. If it's throat symptom. If it's chest symptoms. Like that they can have. And there is no sick contact with this thing. So let's go to this case. Again, MCQs. 8-year-old girl with a high fever of 5 days duration and bad cough with a normal respiratory rate and right-sided crepitation. This is an X-ray. What antibiotic you will start? This is basically a community-acquired infection. This is not a resistant infection from the ICU or from the hospital. 8-year-old going to school. So the antibiotic will be amoxicillin because this is usually Streptococcus pneumoniae. And amoxicillin, 95% of all Streptococcus pneumoniae is sensitive to amoxicillin. Don't use that other, especially azithromycin. Please don't tell. It is a very important drug kept for mycoplasma or mycoplasma pneumonia. So, and it's got and typhoid. So it's got a long half-life. So the chance of resistance is much more. So please don't use azithromycin in children unless it's indicated. 8-month-old female, weight is 8 kg, loose stools for 2 days, no blood, fever, vomiting present, severe dehydration. We admitted with IV fluids and started on amikacin. Stool, WBC is 5 to 6, few RBCs, discharge on Norflox and metro combination. Where are we now? Is it right? Loose stools 2 days, improved very fast. Dehydration you corrected with. There was no need for antibiotic. WBCs were normal. And RBC, few RBCs, everybody will have that. So no, most likely is caused by the rotavirus or enterotoxigenic E. coli, which does not need an antibiotic. Shigella is unlikely as there is no blood. This type of diarrhea is self-limiting. 3, 4, 5 days they become all right. No benefit by the antibiotic. Mainstay is ORS, continuation of the feeds and zinc for 14 days. But stool report, I have already told it is normal. There is no need for most of this thing. Now, visible blood is the best indicator for shigellosis. So when should the antimicrobial given in antibiotic? Bloody diarrhea, amoebiasis, giardiasis, cholera, diarrhea associated with systemic infection, immunocompromised host having severe PM, like you have HIV patients, all those. So basically, only when you see blood, you can start, or you have a diagnosis of amoebiasis, giardiasis, cholera, what we don't see now. And any systemic infection, they have diarrhea. Then you can start on antibiotic. Comment on amikacin? No, it's not a good this thing in this case. Even indicated amikacin, it is not appropriated. Suggested antibiotic of bloody diarrhea, first line is Cipronor, not approved by the DCGI because it can cause some growth plate problems. Second line is azithromycin, cefixime, and ceftriaxone. And these are the antibiotics not indicated for bloody diarrhea. What are those? Fluroxylidim, first and second generation cephalosporin, antibiotic, aminoglycosides, colistin, amoxicillin, chloram. This should not be used for any bloody diarrhea. Need for metronidase? No, because in our studies also almost about 10,000 kids in during the 80s had a lot of amoebiasis, but now we don't even see any. I have not seen a amoebia in stools for a very, very, very long time for that. So this is a 15-year-old child with a vivax malaria and a platelet count of 67,000. No other organs dysfunction, which is the anti-malarial use. Artemether, though the artesunate compounds are a must for the falciparum malaria, for the vivax malaria, we can still use chloroquine with the primaquine. So that if you use that, the resistance will develop faster. 3-year-old with develops UTI, stable, not sick, child started an antibiotic, culture shows E. coli. Which of the following sensitive antibiotic you will give? This is a 3-year-old, febrile UTI, not sick, E. coli. These are the antibiotic sensitivity: sensitive nertefurentine, amikacin, piperacillin, tazobactam, meropenem, coramtrigal, and amoxicillin. The drug is, though it is showing intermediate sensitivity, amoxicillin starts getting highly concentrated in the urine, 10 times the normal blood values will be there. So amoxiclav is a better drug than a normal this thing. Now coming to the last part of my talk for 5 minutes, that is when we say stewardship. One is that you have to diagnose it's a bacterial infection. What type of infection, whether it's a monotherapy, it requires a polytherapy which does not require antibiotic. This is what is called as a diagnostic stewardship. Second is antimicrobial stewardship. Once you diagnose, what type of antibiotic you do, dose, duration, how long, what to use. This is what is called as a antibiotic stewardship. Antibiotic stewardship is a systemic effort to educate and persuade prescribers of antimicrobial to follow the evidence-based prescription. It should be evidence-based in order to stem antibiotic overuse and thus the antibiotic resistance. So all we have is evidence-based. So you are using an antibiotic, and that's the antibiotic which is needed for the organism which is in your community, and at the right dose and right duration as well. Antibiotic stewardship effort should focus on optimizing appropriate use rather than simply reducing the use. No, we have to optimize the use. Patients who have bacterial infection will definitely need antibiotics. So we have to make sure that it is there always. So antibiotic prescribed namely in the hospital, outpatient clinic, veterinary medicine, very, very important. Veterinary medicine is one of the major cause for the antibiotic resistance, what we are seeing in the patient. So how we can be good antimicrobial stewards? All of us have to become, all my undergraduate friends. I think you should, when you come, you should make sure the pledge. I am a person who follow the antibiotic stewardship. So I use rational antibiotic therapy. This is the thing what you need to do. Making accurate diagnosis, diagnostic stewarding, taking culture at appropriate times. So before you start the antibiotic, make sure you take the culture. Selection of the most appropriate antibiotic, duration, dose, and route of administration for given to the patient. Regularly reviewing the need for the therapy. Over the time, your ICUs or your wards may be resistant to certain antibiotics. It's a time for you to change. Minimizing unintended consequence of antimicrobial use, including toxicity, selection of pathogenic organism, and emergence of antibiotic. This is the whole antimicrobial steward. If you go to UK or US, they have the whole thing. Even in India, the major corporate hospitals have this thing. It's all interconnected, each one. Say, for example, in England, if you have to use, even during that time when I was there, if I have to use a higher antibiotic, I have to talk with the infectious disease control pharmacist, then take this thing, explain why I am using the antibiotic. What was the drawback and why these antibiotics are not using, then only able to get a thing. In summary, Encourage parents to record fever. Sudden onset of fever is generally viral because the first, second, third day high fever. Third day onwards, it starts coming down. It's usually viral. It is often possible to differentiate a viral fever from a bacterial one. Leukocyte is a poor indicator because we do the CBCA, we see the high count. See, whenever there is a bacteria or a virus comes into the body, the first reaction of the body is what? To kill it. So it will make sure a large number of leukocytes are transferred from the bone marrow into the circulation. So first couple of days, CBC is not a good indicator. So please don't do CBC on the first day. Wait for a couple of days and then 3 days, most often viral. You wait and then do the CBC. Do not use polytherapy. 1, 2, 3, 4 drugs. It is not needed. See, when is there a diarrhea? What is your diagnosis? Why you want to use the combination of bacterial, that is norfloxacillin and metronidazole? Are you thinking of bacterial and this one, protozoal or infection? No, don't please use those things. Indiscriminate antibiotic treatment can make the test result in interpretation difficult because what happens, your culture result will be negative. Multiple antibiotics empirically can delay the diagnosis of major fatal illness. UTI must be considered in a child with a fever without focus and diagnosed by culture because small children, they don't have any focus, they don't have any symptoms of burning maturation. But recurrent infection of UTI can give rise to scarring and end stage this thing by the time they reach 40, 50 years. Newborn with fever should not receive oral antibiotic and should be referred early to the pediatrician. So this is what the column, our beloved President, late APJ Kalam says, widespread use of antibiotic promotes the spread of antibiotic resistance. Smart use of antibiotics is the key to controlling its spread. Kindly pledge today that you will be an antibiotic steward and make sure that you always use antibiotics sparingly. Thank you so much.